Thank you for sharing those unique models across other states that we're learning from and how they're actually improving patient outcomes and having improved financial outcomes as well. The report also highlighted that patients with Medicaid or Medicare Advantage also experience longer wait times because of prior authorization and other insurance-related barriers. Can you tell me more about this? And what are some of the insurance-related barriers that lead to discharge delays for patients needing SNF care here in North Carolina? And if there's some additional solutions that can improve this process?
Yeah, it's gotten so much more complicated, Alicia. When I started this work 24 years ago, probably more than that, we only had a couple of payers. We worked with Medicare and a handful of Medicaid plans. And so as we have seen the payer landscape change, now we're moving towards more managed care products. The case managers are working with more than 20 different payers, all with different rules, different post-acute networks, arduous administrative burdens. Just keeping up with that, as you can imagine, is really complicated. Well, let me start first by talking about the Medicaid program. So I think DHHS has done some great work to develop strong delivery systems for our most vulnerable patients in North Carolina. And there's some really exciting parts of that. They've got some really great plans for how they're going to move forward. But unfortunately, there's also a part of it that is a real challenge for us and for the community. So the study that you mentioned earlier that the Transitions of Care Committee just recently completed, one of the things that stood out that was a bit staggering is that Medicaid patients represent over a third of the patients in our study and have the highest average excess days. And when I say that, what I mean is days that individuals are staying in the hospital longer than they need to be, so their clinical care is done. And so for the Medicaid population in this study, the range of excess days were between 80 and 150 extra days. It's hard to fathom being in a one-room hospital bed for 80 to 150 more days than clinically you need to be there. So the other thing that was really striking is that majority of those patients were waiting for skilled nursing facility care. Fortunately, what we're hearing from our skilled partners is that in order for them to be able to take care of these patients we're talking about today who have the more complex needs, we would need to move to the tiered payment system that we've been discussing. It's not possible for them to expand services that they offer if we're wanting for them to install equipment for bariatric patients, or if we're wanting for them to have more units for people with severe cognitive or neurocognitive disorders where there's risk that the patient might wander out of a building if the structure and the environment of care is not appropriate or the staffing's not appropriate, or if we're asking them to take care of our aging population with behavioral health needs without different partnerships, different funding sources. So they're going to need to be able to hire a different complement of staff in order for them to accept our Medicaid population. And what we're hearing from them is that the payment structure would need to be different. On the flip side, Medicare Advantage is different altogether and complicated for a very different reason. So what we hear about from our SNF partners around accepting our Medicare Advantage population is that their rates of pay and the administrative burden connected to those payers is often why we don't get bed offers. What they've shared with us is that if they accept a patient under Medicare Advantage, within a few days, they then have to complete a lot of paperwork just to request for them to stay longer. And that's really hard for them to keep up with. So while all the SNFs or skilled nursing facilities will accept some patients with MA plans, what they're saying to us is that they tend to try to keep the percentage in their building lower so that they have the income that they need to take care of the whole population. So it takes longer for us to find a facility that's willing to accept Medicare Advantage at all. So I think with both of them, I mean, if you can imagine, if you live in Durham and you need to go to a nursing home after your acute stay for some subacute rehab or even long-term care, and someone like me comes in and says, I was able to find a facility for you, but it's 45 minutes from your home, that can be pretty jarring. So I think most people just don't realize, because we live our lives not anticipating being sick or being hospitalized or having those needs. And so most people think, well, I have insurance, so I'll be able to get the care that I need. And so when they get to the hospital setting, they're already managing a really dramatic event. Nobody expects to go to the hospital. And so it always is pretty overwhelming when someone is admitted. And so nobody also wants to need to go to a nursing home. And so then if I say, well, you not only do you maybe need that, in addition, it's not going to be where you want it to be. So we've got families who will be advocating for their loved ones, going to local facilities, often begging them to reconsider to take their loved one. So it's pretty heartbreaking because the more complex the need, the fewer facilities that will offer a bed for both payers. So in addition to that, Medicare Advantage just doesn't pay for long-term care. So patients are stuck in acute care hospitals for months because they have clinical needs that aren't conducive to a short-term stay in a facility. So Medicare Advantage isn't going to pay for it. And most families don't have the finances to just pay privately for long-term care. So they're trying to liquidate assets or trying to figure out how to apply for benefits like long-term care Medicaid. And this takes time. So like I said, patients and families are just often shocked. They think, well, I have insurance. So if I need this, then it's covered. If I'm going home with complicated IV antibiotics and a tracheostomy, surely you're going to send a nurse to be with me all day. And so when the case manager and the medical teams explain insurance does not cover what you think it's going to cover, families are really overwhelmed and then forced to just make some incredibly hard decisions. So the payer landscape is getting more and more complicated. And then in addition to that, what we're finding is that the patients and families have just a very different expectation of what's going to be available to them compared to what the reality is and what their insurance will pay for.
Thanks, Katie, for helping us better understand some of the payer factors that are impacting these discharge delays, in addition to some of the clinical complexity that we discussed earlier. As we look at some of the other non-clinical factors beyond the payer, how does not having a healthcare or financial decision maker impact these discharge delays, particularly for those waiting for a skilled nursing facility?
I'm glad that you asked that follow-up question. Talking about guardianship issues feels really important for people to understand. So it's been really striking to me as this committee has really allowed me to see that across the whole entire state, we have many patients who are stuck in acute care hospitals waiting for, a court-appointed guardian. And so the reason is the process is really complicated. And I think we could and should simplify it. So we have patients whose loved ones have been trying to care for them in the community. Their cognitive status has been declining over an extended period of time. And then they reach a point where it's just impossible for them to continue to care for their loved one at home because they're wandering or they are getting confused and doing things that are high risk for them. Or an individual has just an acute event where all of a sudden the way that they think is incredibly different. They're no longer able to take care of themselves. And families and patients or EMS in some situations will bring them to the hospital. We tend to be the safety net location for situations like that. And the way that our system is set up now is if that person doesn't have a healthcare power of attorney or a power of attorney or someone who can step in and make decisions, we're put in the position of trying to figure out who can be their advocate. And so the way we do that is in North Carolina, if there is not someone that legally is able to make those decisions, is we will go down the route of getting a permanent guardian. And that can take months for us to be able to walk through that pathway. And it is a really big decision to say somebody no longer should have the legal right to make decisions. And so what I really wish we had is an ability to have a temporary guardian or an order that would put someone in place to be a patient's advocate to help make medical decisions for them, to help them make the really complicated financial decisions. So we're talking mostly today about transition to skilled nursing facility. Well, it's very costly. And so if somebody has resources, there needs to be someone who is acting on their behalf to make sure their resources are protected and that they are paying for the care that's needed appropriately, or if they don't have finances, to untangle all the information needed to make a Medicaid application. And so right now, these individuals are landing in the hospital. They don't have somebody who can act on their behalf. So we are going through the court system, and it often takes months to get to the point where we even have a court date. Then somebody gets appointed to be their advocate. All along and over those months, there is not that legal decision maker. And so hospitals are put in the position of trying to make the best decisions for their patients within their care, when really that patient deserves an outside guardian or advocate or individual who has been approved to make decisions on their behalf and who can advocate for us to quickly make these transitions of care to the locations where they need to be. So if they need to continue to have subacute rehab, not waiting for 2 months to be able to make that move into a nursing home is really important.
Thanks, Katie, for highlighting the number of the findings that we had from the report that the Transitions of Care Committee conducted earlier this year. You've given us so much to think about. What are some things policymakers can do to help support patients to get the right care at the right time?
So my hope for North Carolina is that since many of the patients we've been talking about also had behavioral health needs, I really hope we can work with the tailored plans that I mentioned to co-design a program. It would certainly take a partnership with DHHS in North Carolina, the tailored plans, skilled nursing facilities, healthcare facilities association, the behavioral health providers, and hospitals. And thankfully, in our discussion so far, it feels like all of those groups are very engaged, aware it's a priority that we need to address. So I'm feeling incredibly hopeful. Obviously, I love the North Carolina hospitals, and I'm proud that I get to serve the patients being taken care of at Duke Health. But I can also say the hospital is the last place anybody wants to be living or should be living. Hospitals are here to help when there's an acute medical need. And as many things, acute care beds are a finite resource. So across the state of North Carolina, we have patients waiting in emergency departments, waiting to be transferred to a higher level of care. So it feels imperative for us to address this so that those in acute crisis are able to access our inpatient beds appropriately. So I can't imagine personally being in one room for 4 months because there aren't resources in the community prepared to take care of me or my family. So I just think we can solve this problem in North Carolina. I'm excited about it. I'm thrilled for the partnership with the North Carolina Healthcare Association. Really loved the discussions we've been having so far with DHHS and the tailored plans. And so I just think North Carolina is ready to make this happen.
I am hopeful as well. And thank you, Katie, for highlighting that it not only impacts the patients that are waiting and impacts their families as well, but it also impacts those that are waiting for acute care as well. Thank you so much for lending your expertise and joining this important conversation, Katie.
Thank you. I really appreciate you inviting me. I've enjoyed the discussion, and I'm really hopeful and excited and looking forward to our next steps.
To our listeners, we're going to keep this conversation going. In future episodes, we'll discuss barriers to transitioning to Division of State Operating Healthcare Facilities. Those are healthcare facilities that offer care to people with specific needs that aren't typically addressed in community-based settings. And we'll continue the conversation around guardianship and those barriers as well, and what happens when a patient doesn't have a legal guardian or decision maker to manage their medical, financial, or personal affairs. Until next time, thanks for listening to In Session.